All right, welcome everyone to the next webinar in our Road to HINAC4 webinar series. I am so pleased to turn this webinar over to Barb Cardell with Positive Women's Network and the great panelists that they have for us today. So Barb, I will turn it over to you.
Great, wonderful. Thank you, Tammy. Hi, everyone. Barb Cardell. I'm the Training and Technical Assistance Director with the Positive Women's Network USA. I use they, them, their pronouns, and really want to welcome you all for joining us today as we talk about why we must include HIV decriminalization in all plans to end the HIV epidemic. We have a translation available, and we're going to just go ahead and click to that slide, and I'll ask Alejandra to go ahead and explain how people can have access to that. But first I wanted to answer, because it seems like there's a question in the chat box about attendees. So yes, we are in webinar mode, and so everyone who is not listed as a panelist will be muted, so you won't need to use your mute button for it to make sure that we get the best sound quality possible. If you do have a question, go ahead and raise your hand, and we'll keep an eye on the participants, and we'll go ahead and take you off of mute so you can go ahead and ask your question in person, or you can go ahead and just put it in the Q&A, and we will be able to answer it when we get to time for questions. So with that, I'm going to go ahead and turn over to Alejandra to go ahead and talk about access for interpretation.
Hi everyone, my name is Alejandra, and I will be the interpreter for today. Hola a todos, mi nombre es Alejandra y estaré brindando interpretación el día de hoy. I'm going to go to this through this message first through the prompts first in English, and then I'll say it in Spanish. So to access interpretation, if you're on a computer, you're going to click on once the interpretation is turned on, you're going to see a globe that appears on the right-hand side, on the lower right-hand side, and you're going to click on that. And then it'll take you to a menu to select your language. If you want to listen in English, you select English, and then you're going to press done, click on done. If you're joining us via smartphone, to access interpretation, you will see the three dots. You're going to click on those three dots, which will take you to language interpretation. You select that, and then you select English if you want to listen in English, and then you're going to click on done. Unfortunately, interpretation does not work if you're joining us, if you've called us through the phone. So it would be best to join via the app if you're in need of interpretation. It also does not work on Linux systems or Chromebooks. So now I'm going to go ahead and talk about, explain it in English, en español. Para acceder a la interpretación, si te uniste a la reunión por una computadora, cuando se encienda la interpretación, vas a seleccionar, vas a ver un globo a la derecha, le vas a dar clic a ese globo y te va a llevar a un menú para poder escuchar el idioma, para poder seleccionar el idioma. Le das clic en español y clic otra vez a finalizado. Si se unieron por medio de un teléfono inteligente, vas a ver tres puntitos. En esos tres puntos le das clic, te va a llevar a un menú de interpretación de idiomas, y ahí después vas a seleccionar el idioma en el que quieres escuchar, seleccionas español y le das clic a finalizado. Desafortunadamente, si la interpretación no funciona, si te reuniste por teléfono, por llamada. Entonces te pedimos, si te reuniste por teléfono y necesitas interpretación, que utilices la aplicación de Zoom. Y luego, desafortunadamente, la interpretación no funciona con Chromebooks o sistemas Linux. Y sin más ni menos, pues bueno, I think we're ready to turn on the interpretation.
Alejandra, I just turned that on. Do you have access to it now?
Oh, but you have to make me interpreter.
Oh, sorry, I thought I had.
Estamos encendiendo la interpretación.
Okay. Do you see it now?
I have not been assigned interpreter.
There we go. Sorry, everyone. Should come up now. Apologize for the delay on meetings. It has brought it up automatically. So just let me know when you get it, Alejandra. Okay, great. Thanks, Barb. Now you can move ahead.
Yeah, absolutely. We just wanted to make sure language justice is such a powerful part of the Road to HINAC series that we really wanted to take the time to make sure that it was enabled before we went ahead and started. So thank you everyone for your patience as we were making sure that that system did work. Again, thank you for joining us. We have a number of presenters today. We have Teresa Sullivan and Gina Brown, who are going to be part of our panel later on, talking about their personal experience with the Ending the HIV Epidemic plans, as well as inclusion of HIV decriminalization. And then we have Allie Watson, who is our If, When, How Fellow with PWN. And many people have met Allie as she has worked with our policy fellowship and a number of great monthly updates and a lot of explainers around a number of complex political issues, including the latest on executive orders that I felt like I just, wanted to print out and hand out to a whole bunch of people who get sometimes confused around all the political stuff. So welcome, Teresa, Gina, and Allie, and thank you so much for joining us here today to talk about this very important issue. So our objectives today are going to be to develop an understanding and a shared language around the Ending the HIV Epidemic planning process. We understand that this has been talked about and often just mentioned, and then people walk away from it and don't really talk about how important it is. So we're going to talk about the process and explain it. We're also going to talk about engagement opportunities for people. We'll talk about where HIV decriminalization language can and should show up in these Ending the HIV Epidemic plans. What metrics we want to use to measure whether or not a plan includes the HIV decriminalization language. We want to talk to Planning Council participants about how they can push this inclusion forward, even if it hasn't been part of the conversation before. We have an opportunity now to really kind of stop and reset and say, you know what, we want to talk more about including HIV decriminalization. We want to talk more about meaningful involvement of people living with HIV, and we want to talk more about how we can now be a part of this very important planning process, because it is going to drive HIV planning as it moves into the future. And then finally, we want to share the experiences and lessons from Teresa and Gina, who have been involved in these planning processes, who will be able to share with us both what has been really good and powerful and what has been really challenging. So our agenda today is that we'll just go through the basics so that everyone has a clear understanding rather than just the highest level of description, and we'll be able to talk about what the specifics are. What are the problems with the plan? This is a federal plan that was introduced in 2019 by then President Trump during his State of the Union, and it has some real challenges with it that we want to make sure now that we have the opportunity to push back and change, that we do so. We'll talk about the planning process, HIV criminalization and where it's included. We'll give some examples of criminalization language in the Ending the HIV Epidemic plan. And I'm going to give everybody a little bit of a warning. Some of it is really outstanding, and some of it is really terrible and cringeworthy. So when we get there, we'll just give you a little bit of a heads up that some of the language is appalling. And then we'll hear stories from the field, and we'll be able to tap into our leaders to share with us how things are and what we know. First, going to give people a little bit of an introduction to PWN. PWN is a national membership body of women living with HIV. It was created in 2009, and it is developed by and for women living with HIV. And we had a founding in 2008, which is what we really consider our birthday. So PWN has been around for 13 years. And our purpose is to support women living with HIV in all of our expressions, including our gender expression. We are trans inclusive and really seek to involve anyone who is working to advocate either as a member or an ally as we are working towards the rights of women and people who are living with HIV. We have a large number of members, and we are across the United States. We have leads in some and chapters in others, and if people are interested, you can go ahead and reach out to either Allie or myself, and we'll connect you. We are indeed working to prepare and involve women living with HIV in all of our diversity, in all levels of policy and decision making. And we often say that unlike a number of other organizations, we are not a support group, but women who come and join up and partner with us find support here and also find opportunities to engage in advocacy in ways that are incredibly important and have great impact on their lives. With that, I'll go ahead and turn it over to Allie to talk about the Ending the HIV basics for us.
Great, thanks so much, Barb. Allie Watson, she, her. I know Barb introduced me, but just so I introduce myself. So we're just going to go over the basics of the Ending the Epidemics plan. Now, just as like a high level thing, when it's talked about at the federal level, they call it an EHE plan. When it's talked about at the state level, it's usually ETE. It's all kind of talking about, you know, the different plans and how they work together, but just in case you see that come up. In our presentation, you have some context for why that is. And it is a 10-year initiative that was announced by the Trump administration in February of 2019. And it began fiscal year 2020, which weirdly is actually October 1st, 2019. And the goal of the EHE plan was to reduce new HIV transmissions to less than 3,000 per year by 2030. Next slide. A little bit about, so the plan is a little bit vague, but there's 4 basic pillars that the plan kind of abides by. The first pillar is to diagnose all people living with HIV as early as possible, to treat people living with HIV rapidly and effectively, to sustain viral suppression, to prevent new transmissions by using proven interventions like PrEP and syringe service programs, and to then respond quickly to potential HIV outbreaks to get prevention and treatment to services to folks who need them. So that's the basics of what the plan kind of intended to do. Next slide. So this is intended to be rolled out in 3 phases. We are currently in the first phase still, but some moving kind of a little bit into the second. So the effort is initially supposed to be focused on 48 counties, Washington, D.C., San Juan, Puerto Rico, and in 7 states. The reason that those places were chosen is in San Juan, D.C., and these 48 counties. HIV, they accounted for greater than 50% of the HIV diagnoses that occurred between 2016 and 2017. So the diagnosis rate was very high, so that's why those were chosen. And then the states that were chosen, the 7 states, have a substantial number of HIV diagnoses, in rural areas. So that's why those were chosen. Phase 2 is intended to expand these efforts across the rest of the country. And then afterwards, the plan is to enter phase 3, which will be a maintenance phase to ensure that numbers of diagnoses don't increase again. So that's the basic structure of how the plan works. Next slide. So after this plan was rolled out, HIV advocates and people living with HIV in this space started noticing a couple of problems with the plan. And one of which is that it's extremely biomedical focused. So it's all about, these biomedical interventions, and there's really not a lot of focus on structural and social determinants of health. And because it doesn't address these, there's really no way to address the HIV epidemic without addressing these social and structural determinants of health. And some of these include like systematic and societal racism, the lack of continuous access to affordable, culturally competent healthcare, medical mistrust, especially in Black and Brown communities for good historical reasons, inadequate and unstable housing and transportation, food insecurity, lack of employment, lack of quality education, and the carceral system. We're not going to be able to end the epidemics until we address all of these things. And the plan doesn't really talk about them at all. It's all very focused on PrEP access, getting access to medical interventions and things like that. So advocates have known for a long time that it's not enough to just have the right medicines. We also need the systems and structures in place that people can trust, as well as the ability for folks living with HIV to have healthy, dignified lives. That's the only way that we're going to be able to address the epidemic. And this plan doesn't really do that. And it's especially true just when we look at the disproportionate impact that these social determinants of health have on BIPOC communities, trans folks, and low to no income folks, especially those people living with HIV. These people are the most impacted by those factors that I just listed, and also they're most impacted by the HIV epidemic. So until we recognize the comparisons there and start addressing them, we really can't move on and start reaching the goals that the plan purports to have. The other thing I'd like to mention is the plan, I skipped over the middle part here, but it's also very reliant on molecular HIV surveillance. This is also referred to as MHS. So MHS is basically, it traces networks of HIV transitions using genetic sequencing data, and it's obtained after a person living with HIV receives a test, but consent is not required to use the data in this way or to share the data in this way. And a lot of folks have been drawing attention to the high risk that this could be used in criminal prosecutions of people living with HIV. And there's also, of course, problems with consent, and it increases those other factors I talked about as well, about medical mistrust and other things like that. And then next slide. So we also have quite a few human rights concerns. I kind of went and discussed some of them in the previous slide, but basically just there's the EHE plan does not at all address reproductive and sexual health rights of people living with HIV. There's not really discussion of LGBTQ+ rights, no discussion of ending any sort of violence really, including intimate partner violence, police violence, community violence, which all can increase a person's risk of acquiring HIV, and then also shows up for folks who are living with HIV in a higher prevalence. There's no addressing trauma-informed care of folks, which is really important, especially for people living with HIV, where the studies have shown that trauma-informed care is really important for people living with HIV who tend to have higher rates of trauma and need this care even more. And then of course, HIV decriminalization is not addressed in these plans, which is what we're going to talk about a lot today. So next slide. So then the third kind of prong of issues that have been identified with the EHE plan is there's a lot of issues around community engagement. So while community engagement is required in the EHE plan, the metrics and how it's measured are not really clear. So to kind of demonstrate this, I just put an example of this up here. So you'll see this is from the Minnesota rollout of their EHE plan. Now, a little bit about how the initial community engagement piece of the EHE plan was met. Minnesota did small focus groups of about 15-ish or so people. And that was used in the drafting process to source ideas from community members. So they weren't really sitting at the whole table with everybody drafting, but they did these small focus groups. So importantly, I couldn't find any statistics on how many women or people living with HIV were involved in the process, but we have some here from the rollout, which is why I wanted to show this here. So this is data from the rollout, and you can see that there's a really small number of people involved. I think there's 59 participants there on the screen that we can see. And most of these folks are not living with HIV. So there's really not a lot of meaningful involvement of people living with HIV in the community engagement section here. It's also important to note, and I think this is something that we tend to forget sometimes, but all of these surveys, they had some in-person meetings, but then the survey data about how the plan was actually going was collected online. Well, 16% of rural Minnesotans don't even have internet access, and rates of internet access are also lower for Black Minnesotans and Indigenous people living in Minnesota, which are also people most impacted by the HIV epidemic there. So we're not really getting meaningful involvement of the people that these policies are most impacting, and also who we need to be involved to truly understand what resources are needed. So yeah, as I mentioned, yeah, there's community engagement here and in the rest of the Ending the Epidemics plan, as we'll see. Community engagement does not mean meaningful involvement of people living with HIV in this plan. And that's something that really needs to be addressed. Next slide. So here we have another community engagement example, and I'll go through this one quickly. Just so you know, my little key on here isn't showing up for some reason, but the GTZ means getting to zero plan. This one is for Illinois. And so the GTZ plan for Illinois, it talks about the community engagement section, and it talks about work groups and things like that, but there's no actual metrics. Which is basically what I was trying to show here. There's no metrics of how many people were involved, who was involved, at least not that we can see, not that's like facing towards the public, that we can really identify, you know, how many people living with HIV were involved in developing these plans, you know, and things like that. And a lot of this discussion as well, which obviously we don't have to read all right now, it's really focusing on how to involve the community after the plan is released, and not developing or not engaging the community during the process of developing the plan. So that is a bit there. So next slide. So to get into the planning process a little bit, kind of moving out of issues and into the planning process, developing one of these ETE plans. Unfortunately, for getting involved in the process, there's no real simple answer as to how to get involved. The plan gives these phase 1 jurisdictions funds to begin the planning process, but how they do that planning process is really up to them. It's kind of a feature of the EHE plan is to have these be really community centered. So they want to give a lot of freedom to different jurisdictions, different counties and states to develop the plans themselves and come up with the process for doing so. The problem with that is that there's no one way that we can tell folks, like, this is how you 100% get involved in your EHE plan or your ETE planning council or something like that, because there isn't one way to do so. So although there's a requirement that community is involved, how exactly you can get involved is a little less clear. Some states make it really easy to sign up. Some states it's a little bit more difficult. So I did include a link on here, and it's a little bit later too on a resource slide, and we can drop it in the chat as well. But you can find all the plans and the different stages of development that they're at. And if you'll go to the next slide, I think I have a picture of the map there. Yeah, so here's a little key on the side that shows basically where plans are being made, where plans are being prepared, where there's no data, and then the big blue dots on there are also the counties. And so, like I said, states are running the community involvement process differently. You can certainly contact, like local authorities, health departments and things like that, and see some of these places like Nevada. If you click on that one, it tells you that it's being led by the Nevada AIDS Education and Training Center. And so you could certainly contact those folks because they're the ones now running the process. And in the states where there's no data, probably a health department would be the best place to go. But there are some states like Texas, you can sign up on a form where you receive updates and other information about the plan when they're having meetings and things like that. And it makes it a lot easier of a process. But there's all different stages, as you can see, where these plans are being rolled out. And then I will say too, some of these plans, they might say they're being made or that they're already made. If you live in one of those states, you can still get involved. Like I showed with the Minnesota example, there's still community engagement processes of the rollout and opportunities for things to be changed, especially like I live in Florida and I know that plan technically is made, but the way they phrase it is, this is a living document. We want to keep changing this as we go along. So you're not out of luck if you live in a state where a plan is already made. Next slide. Okay, and then this is just a little bit more about the community engagement piece. As I said, there is some guidance from the CDC on how to engage the community, but like I said, it's not clear like what metrics are needed and everything like that. Jurisdictions are being required to allocate at least 25% of their funds to support planning and implementation by community organizations. That is a good aspect of the plan, but again, if we want meaningful involvement of people living with HIV, this doesn't quite cut it because there's no real requirement of a certain number of people involved in these planning decisions. Next slide. All right, so now we're going to go into a little bit about the basics of HIV criminalization, and just to kind of see how, now that we've gone through the EHE basics, the issues with that process, the planning process, and how we maybe can get involved, we're going to talk a little bit about HIV criminalization so we can see how those two intersect. So just as some background, I'm sure lots of people know here on the road to HINAC that more than 30 states have laws criminalizing HIV transmission, exposure, or non-disclosure. And these criminalization laws are disproportionately enforced against BIPOC folks due to racist policing practices and structural racism, as well as people who do sex work and people of trans experience. Also, as a side note to those later two, or at least and people who do drugs, use drugs as well. I forgot to put that down there, but they are not left out, of course. There are laws that further use the possession of, condoms or extra syringes and things like that as evidence for certain crimes. So sometimes those activities are criminalized as well, which kind of fits into this HIV criminalization piece because it discourages safe sex practices, safe drug use practices, and things like that. So I wanted to I see someone's asking me to hold up for a minute.
Yeah, sounds good. So Anna Forbes had a question that she wanted to go ahead and talk about. So Anna, I'm going to go ahead and see if I can. Tammy, can you promote her to a presenter or take her off of mute so that Anna can go ahead and ask a question or raise a point?
Can you hear me now?
Sure can. Welcome, Anna.
Okay, I'm sorry to be intervening, and especially since I'm a little late coming in, but I had a thought that I thought might be really interesting to bring here. I am 66 years old. I have been doing HIV work since 1985, and that's relevant only because I wanted to tell you a little bit about, real quick, about what we did when we weren't being listened, when people with living with HIV were not being listened to, when they were first setting up the Ryan White plan back in the early 80s. And it was the same sort of deal in that the administration, the government was insisting that the funding for this would be handled a certain way, and the health departments had a certain role in it, and other administration people had a certain role in this, in their cities, etc. And they were really trying to push very strongly for how the funding was going to be used, and what people living with HIV needed, and what services were going to be organized, and who got say on that. They were pushing it very hard, very much in the same way it sounds is happening now. And I was in ACT UP in Philadelphia at the time. I was also working for the health department, which the health department didn't find very entertaining, but that's the way it was. And the people living with HIV organizations there were very concerned about how they could get themselves sort of in on this process, and being heard about how the funding could be used and so forth. And basically what happened in Philly, and I know it happened in a lot of other cities as well, is that people living with HIV just had to march into some of these meetings and say, look, we're not going to sign off on this plan that you're proposing, and we are going to be very visible so that the federal government will know that there are PLHIV organizations here who have very strong feelings about this and how the funding should be used, and who are not being heard, that the people handling the money are refusing to listen to them, and refusing to work collaboratively with people living with HIV about what their real needs are. And I just wondered if we've considered using that strategy again, because I think that it's sort of it's an inevitable cycle that when there's large amounts of federal funding coming out, people try to hang on to it, and the more influence you have as an organization, or as a city funded or a publicly funded health department, etc., it's going to be hard to get their attention. It's going to be hard to get them to stop and rethink and listen to people living with HIV. But I think it's a very good place for civil disobedience, if that's what it takes to do it. So I just wanted to bring that in, and I was curious if people know of any actions like that happening with regard to the funding now, and how, if so, how that's going.
Yeah, thank you, Anna. If people have heard of any organizing, especially disruptions that people are planning or have seen, if you want to go ahead and mention that in the chat box, that would be great. And I think this is also a great question for us to carry into our panel that we have coming up after we do a little bit more of our general information and education. And I appreciate Anna bringing up the call for disruption, because I think that is absolutely one of the tools that we have in our tool chest as advocates. So thank you very much, Anna.
Yeah, thank you so much, Anna, for sharing that especially for, you know, some of us who maybe weren't doing this work then, it's really good to always have that history around it too, and different strategies that have been successful. So yeah, HIV criminalization laws obviously perpetuate HIV related stigma. They impede the public health goals that obviously could help with these EHE pillars that they keep talking about, you know, testing, treatment, prevention, all of these things that EHE purports to be about. Reducing stigma is a huge piece of that that's being a little bit ignored, and HIV criminalization is one way, because of course, when something is criminalized, obviously it's also stigmatized as well. There is, you know, studies that it could disincentivize testing and things like that. It also increases medical mistrust, especially Black and brown folks who are disproportionately criminalized by these policies. I'd also like to note that we were talking a little bit earlier about those social determinants of health. Criminalization laws reduce the ability to get necessary food and services to, you know, support those social determinants of health, like housing, food, employment, all of those things. It clearly negatively impacts all of those elements as well, which are really important. And folks who bear the highest burden of accessing those things also tend to bear the highest burden of criminalization and the HIV epidemic. Okay, next slide. So now let's talk a little bit about talking about decriminalization in the EHE framework. So here, I'm just trying to think about, they've got the 4 pillars that are in the plan already. It's that diagnose, treat, prevent, and respond framework. So how can we fit HIV decriminalization into that framework and talk about it a little bit in that way? So obviously treatment is affected by those social determinants of health that we discussed earlier, especially the structural racism piece that really cuts through all of the rest of it, until we address these like structural racist forces that are going on in our health system, our government systems, just society as a whole. We really can't, we aren't going to be able to effectively deploy treatment and things like that, because if folks don't trust the systems that they're getting care from, they're less likely to get care. And it's a rational thing to do if those systems are dangerous to you. So yeah, and then HIV criminalization also disincentivizes testing, which is another piece of that, those pillars that the plan focuses on, and it makes it more difficult for people living with HIV, and even just in general, people who use drugs and sex workers to practically safe, or to use safe practices. Again, I discussed this a little earlier, but the stigma around HIV, which is increased by HIV criminalization, makes all the steps more difficult of ending the epidemic. And it increases distrust of the public health response from Black communities, who account for a higher proportion of new HIV diagnoses and people living with HIV. And if the EHE plan is really trying to target ending the epidemic, we really need to focus and hear from these folks, you know, BIPOC communities, about what they need, instead of just doing this very biomedical focused approach. Yeah, next slide. So just a little bit about where HIV decriminalization is included in these state EHE plans. So in terms of what I was able to find, I think someone noted earlier that maybe Alabama has a plan that's been developed that I wasn't aware of. But in terms of what I was able to find, HIV decriminalization is included in Texas, Illinois, Florida, Washington, California, Minnesota, and New York. And it's absent in Arizona, Colorado, Oregon, DC, and Rhode Island. And so some states have explicitly discussed decriminalization, and those are the ones I've listed, and others have just completely ignored it. I would like to note that some of the states that have discussed it haven't always done it in the best way. You can talk about HIV criminalization and include that in your plan, or talk about a criminal justice system and maybe do it in some problematic ways. So we are going to look at some various examples of the language used in these state ETE plans. And in case anybody on here has participated in some of these processes, this is just a learning opportunity. I'm not like fully condemning or fully endorsing any of these plans. There's a lot of different pieces to them, and I was able to just narrow down and focus on one piece of them. So not shaming anyone who worked on any of these, just trying to discuss the different ways that we can look at this language, especially around the area of HIV decriminalization, and maybe try and improve it for folks going forward and engaging in the planning process in the future. So next slide. So the first plan I'm going to discuss, this is actually, I picked Florida because that's where I live. So this is Florida's draft EHE plan. So I have it up there on the screen right now, the piece that talks about HIV criminalization laws. I do want to make a note that Orange County in Florida explicitly called out addressing HIV criminalization as a need in the process. And we're not talking about the specific Orange County piece of it, which was different than the statewide plan. So Orange County people, I am not talking about you. So I want to spend some time unpacking these issues. So as I mentioned before, MHS is that molecular HIV surveillance that's taking people's data without their consent and using it to, map out different maps of HIV transmissions and things like that. And there is a risk there of criminalization. So this is talking a little bit about that, just for the context of where we are. So here, there's a couple issues that are pretty obviously missing. So it's not at all addressing the stigma that is associated with HIV criminalization and the barriers that HIV criminalization poses to ending the epidemic. This is much more focused on, we need to talk about this to get community buy-in, but it's a little bit hands-off in a way that we don't really want to talk about it. Just also as a side note, Florida has a very harsh HIV criminalization law. And the actual transmission is not required, which will become important in a moment. So actually, we can talk about it now. So kind of at one of these, the last line here, it says, education to the community at large is needed on the recent advancement of biomedical interventions since HIV. I'm reading the language here, and some of the language is problematic, as Barb mentioned in the beginning, but HIV positive patients on medication are unlikely to transmit the virus to others. It's talking about that in the HIV criminalization section, which would lead someone to believe like, oh, okay, so someone who is virally suppressed couldn't be criminalized under this law. That's not true. So this last line, even if you educate the community about the U equals U, undetectable equals untransmittable, that does nothing to address the issues of HIV criminalization in Florida. It also does nothing to address the stigma and things like that come from HIV criminalization. I'd also like to say that it's, as I said before, nothing is exactly saying to decriminalize at all. So they include this. And if you're reading through the plan, you might say, oh, great, they're talking about HIV criminalization. This is wonderful. But it completely misses the issue of they're just trying to get, it says in here, community buy-in is risked if we don't address this. So let's throw it in here. Next slide. So this is another part of Florida's plan. And I just really want to focus on basically the last two lines. It says, over time, FDOH, which is the Florida Department of Health, has built relationships with county jails to establish HIV testing and linkage programs. Increased partnerships with county jails are needed to expand HIV, STI, and HCV testing. Now, it talks about strengthening these connections between the Florida Department of Health and county jails, which is not great where HIV is also heavily criminalized in this state. And there's no discussion around here about the problems that might arise from having a public health response tied to a carceral system, especially because the HIV criminalization laws in Florida are disproportionately used against Black women. And those women also tend to have a higher incidence rate of HIV acquisition in the state. And so those women are not going to be likely to trust a public health response that's also criminalizing them. So if you're looking at ways to link people to care, doing it through a county jail is not a great way to do it. That just increases those medical mistrust concerns that we talked about before. People are not going to want to take HIV tests in a place where it's also highly criminalized, especially if they're a person who uses drugs or a sex worker, things like that, because it increases their risk of criminalization, and linking a health response, a public health response to the criminal system, and just increases that mistrust. It increases stigma. It makes it think that, you know, I don't know if I mentioned this before, but there's also evidence that HIV criminalization and increasing stigma, sometimes that increase in stigma can lead to mental health struggles in people living with HIV. It decreases testing. It can make it more difficult to adhere to medications if you are having, you know, a great deal of stigma. And then also it can lead to intimate partner violence. So if we're talking about ending the epidemic by really allowing people to live healthy, meaningful, dignified lives with HIV, this is not a great way to do it by increasing stigma. Okay, next slide. Now we're gonna get to the good part, some good language, so don't worry. So here, this is some language from New York's plan. And the main thing I wanna focus on here is, I discussed a little earlier, so New York does not have a law. Well, they may have some problematic laws around HIV criminalization, but they don't have a specific HIV criminalization law. And they do talk about in this plan the need to decriminalize the use of, to decriminalize condoms and carrying around extra syringes and things like that, increasing syringe service programs, making it easier for people who use drugs to maybe get into treatment, mental health programs and things like that. So they're, instead of pushing this further into a criminal space, they are going to work to take it out of that space and push it more into a public health response that addresses a vast number of things and not just, you know, the biomedical aspects of this. So they're talking about, you know, we want to help folks get housing. We want to make sure they're not going to jails for just carrying around some condoms. Like, we want to incentivize those safe practices. So this is an example of some good language that's been done. Next slide. Okay, so this is from Minnesota, and there's a couple things I want to talk about here. So Minnesota here, it talks about intersecting oppressions for one thing. So it's talking about gender, race, ethnicity, sexual orientation, poverty. So it's hitting on all of those different determinants of health. And it talks about how criminalization and the criminal system undermines the public health response that's needed. It also provides a comprehensive definition of what stigma and discrimination is. I'm sure there are ways we could nitpick it, but besides a lot of the other plans I was reading, I was like, this one finally provides something about, you know, what stigma and discrimination, what negative influences those have on a public health response, and how we can have a more comprehensive response by addressing some of these social determinants of health, the racism, the gender oppression, and things like that. So I want to definitely give our panelists some time, but if there are any questions that I missed in the chat, I can take a second to answer those. I don't know if you saw any, Barb. Yes, we can get copies of the slides later. They'll be sent out to everybody who registered.
Yeah.
But that's all. I think I'm going to pass it off to Gina then.
Sounds good. So I'm going to go ahead and just hop in here and frame a little bit of our conversation. So we have both Gina and Teresa who have been involved in their local EHE plans, who are also longtime advocates and leaders with PWN nationally and internationally. And we are really fortunate to have them with us today to be able to share their experience. And so we're going to give each of you a chance to talk about what it's been like in your particular area. And then as we have time, we've got some questions that we can ask them both, as well as can take questions from the audience. And so Gina, do you mind talking a little bit about your stories from the field in Louisiana and what it's been like?
Yes. Well, hey, everybody. Thank you all for having me. So I started in the process with the EHE plans before we even had a Louisiana plan. When we first got together in Atlanta, I was on board then. So when we came into Louisiana and started doing the work, what I found to be really disheartening is there were a lot of providers at the table from the beginning, and then they started saying they wanted people from the community. And people from the community don't always feel comfortable walking into a space that's already heavily provider focused. So it's been really, really hard to get people to become a part of the process in Louisiana. New Orleans, because I think it went through Women with a Vision, it was a little different because they're used to dealing with community. So I'm trying to read the arrow, y'all. And as far as criminalization goes in Louisiana, I think people thought they did something when they got them to change the word AIDS to HIV. And we're still dealing with legislators who are not, they're not up on the science. And even when you bring the information to them, they don't get it all the time. And I find that even in the room, when you're talking in that ETE room with other providers, sometimes they don't always say that they're against decriminalization, but you can tell from their body language and the conversation they're having that they're against it. They still have providers that believe that that people who are living with HIV should be policed. We should be somehow tied and made to act a certain way. A big thing that I'm finding, and Allie, you may know this too, with these EHE, ETE plans is we're really relying on the HIV community. So that's providers and people within the HIV community to get this work done. And we're not going to end the epidemic by keep talking to us. We got to talk to them. You know, we got to go out and talk to people in the community who are most impacted by HIV and get them to the table so that they can tell us what it is that they need. You know, I was listening to you, Allie, when you were talking about people not wanting to get tested because of the stigma with criminalization and all of that. You know, it's huge in Louisiana. You know, when you go out and you're talking to people about knowing their HIV status, they don't want to know because they know they can go to jail. You know, and how can you go to jail for something that that if I'm on effective meds and I'm doing everything I'm supposed to do and I'm undetectable, I cannot transmit HIV. And you talk to legislators and you talk to planning people and you say this over and over, and it's like there are a lot of people who still haven't bought into that. So I think that in order to, and I'm going to this goal 5, you know, achieving a more coordinated response, I think we have to do a couple of things. We have to stop talking to each other and talk to people who we want to get this message. We got to start there. And another thing we have to do is we have to make sure that that if we walk in a room and we don't see community in that room, we figure a way to get community in that room. Because if our fingerprints are not all over these EHE, ETE plans, you might as well throw them in the garbage can. You know, And I'll stop there.
So Gina, before we pass to Teresa, I just want to harken back to the question that Anna asked about community pushback and disruption. Have you seen any? And do you feel like in Louisiana that there is either opportunity or need to be at that place yet?
Haven't seen it, and yes, there's a need. There's a huge need for disruptors. There's a huge need for, I think in Louisiana, we've gotten so used to making noise in a polite way by not, not really getting as wild as we should at times. I think as wild as we get at a Saints game, that's how we should be talking about HIV. That's how we should be approaching HIV, that same way. So yes, there is a need and there is an opportunity for it to happen. And y'all know I love protests and I love action. So just call, I'm there when it's time, I am there.
All right, thank you, Gina. I appreciate that, and we have indeed time to disrupt. And, you know, who dat? So indeed, we will wait and see how that develops. So thank you, Gina, for sharing the experiences in Louisiana, and we will hear from both Teresa and Gina a little bit more as we have a panel conversation. And I will go ahead and pass it to Teresa next to give us just a little bit of an overview about what your experience has been like dealing with.
Yes. Hey, thanks, Barb. I read through EHE several times with the hope that I would find some kind of language in there that is talking about how we end the epidemic by also ending HIV criminalizations of people living with HIV. I did not find it. What I found was a lot of things that Allie said about biomedical statistics and data collection. They did address certain things like stigma, racism, housing being the gaps that are missing, which we already know. But when I got to the part to read where community engagement was supposed to be there, thinking back on the Denver principles, where it says that we create our own caucuses and making sure that our people living with HIV are on planning councils and community advisory boards. I read where they did interviews of like maybe 500 people here, 2,000 people there, and then they called that the voices of people living with HIV being supported in this plan. I call that a cop-out. Because there was no meaningful involvement of people with AIDS at the decision-making tables before they rolled out this plan. If it was some there, they didn't have a lot of input into how this should run and be rolled out in the first place. So it takes me back to where Anna said, because I live in Philly, and where we are very active about protesting and demanding what we need for our health department, from our government, our legislators that run our state laws and policies in Pennsylvania, even on a local level of Philadelphia, that there was a lot of gaps, and talking about the gaps, but I didn't see any resolutions. Right, I seen like the bare minimum of what they could come up with, and I take a back seat to that and feel real disheartened, like Gina said, because they didn't involve us. Right at the you ever had been invited to the meeting after the meeting? That's how it felt when I read through that. Like these decisions were made, and there were no input from people who actually had the lived experience, and the subject matter experts, as Barb always says, were at these tables. And we were thought of like an afterthought, or put in as a piece for like a focus group to get some kind of data collection. But people got to remember, some of that they collected is self-reporting. right? And that has a lot of holes in it, right? So you're not really collecting all the data that you should be collecting, and it's not qualitative at all when you roll it out in these plans. It reminds me when me, Barb, and PWN at a conference in 2010 when Obama was the president, and we were offered to read through the ACA. And what we've seen as an organization that is primarily focused on women living with HIV, inclusive of our trans sisters and trans justice and sex work, we did not see any of that being addressed in that plan. So again, here we come again with a new administration who wants to roll out these EHEs or ETHEs without the input of the community, right? Without the subject matter experts at the table. We believe that what we bring to a table is just as valuable as those researchers, right? Just as valuable as those organizations that, being real transparent at the table because they want some of the funding, right? Where we want to end the epidemic in the lifetime of people living with HIV. That's what we want, right? And in order for that to happen, we have to really address the root cause analysis that makes people vulnerable to HIV in the very first place, like housing, adequate health care, for women, who are experiencing intimate partner violence, talking about childcare for women, right? Can put women at vulnerable to HIV, right? Talking about addressing the stigmas surrounding HIV and people afraid to get tested because they're afraid if they test positive and if they didn't disclose their status, then they, depending on what state they live in, they can be brought up on some bogus charges, even though HIV was not even transmitted, because it's all about exposure. Pennsylvania doesn't have a statute, but what we do have, which is just as bad, is we have provisions, which means sentence enhancements, where you could be charged for one specific charge and had things be added underneath that, where it could lead to a felony. And we all know that getting a felony puts you at a disadvantage of getting employment, getting housing, higher education grants, also put you in a vulnerable place about housing in traditional ways where you are maybe on a low income and you need those assistance and those resources so you can put a roof over your head, but also making sure it's stable housing that you can afford. All that's wiped away once you have those felonies placed upon you. And in our plan, I'm not saying that it's not a good plan. I'm just saying it's not comprehensive, right? That there's a lot of holes and leaks that we need to address. And the only way to plug that is for people living with HIV to be at the decision-making tables, right? And say, like, this is okay, but this does not work. And telling people who are have the money and who are trying to roll out this with all good intentions, but what they're forgetting and what they're lacking is the involvement of people living with HIV at the decision-making tables, bringing truth to power about what really works in our communities, especially Black and Brown communities. We're already marginalized. We're already oppressed, right? We all already have so much stigma and misbelief about government or any kind of rollout already. And that has to be addressed too. Awareness and education true education needs to happen. Not just saying that, okay, we educated these many people and we're gonna write this in this plan and say that we did a great job. That is disserving the people living with HIV in our communities on so many levels. And we want to change that and get back to what Anna was saying about disrupting. I'm all in, right? Because we have to sometimes. We have to make some noise to let people know that we are here, we're not going away. And you need to make sure that we are not just at the table. I like to say I'm dancing on top of the table, because you're going to see me, you're going to listen, because my voice matters, because my life and those that are in my community of people living with HIV lives are at stake right here, right? It's not just about you getting these plans rolled out, disseminating some funds to say that you did the most you could do. Well, guess what? You didn't do good enough. Right. And for us to be at those tables saying that and making sure that we had planning councils, making sure that we're part of research planning, making sure that we are going to our health departments, demanding to be on certain committees, right? And not have them say, well, we got one of those. That's tokenism. We don't want to hear that. Right. And we also want to make sure that as we go to these places, we bring people along with us. Right. Just in case there might be a time where I can't be there, but I got a backup, right? Or some backups, right? That can be at those tables. And also what's really important for us is to educate ourselves around what we are getting involved in. We want to be very productive when we get there. We want to make sure that we have a strategy in our minds or on paper, and we have an agenda and things that we want to talk about when we go there. Right. If you have to go and just listen for a minute, but be prepared, it's really important for our community, and educating ourselves and doing our own research, but also bringing people along with us is so important. That was a lot.
But you know, Teresa, you saying that it makes me think back to the old days at the planning council. Mm-hmm. And they basically would tell us that they wanted us in the room, but they really didn't want us to talk. So they would give you food and they would feed you. And you sit there and you'd be chewing so you couldn't talk. So I tell you, no, don't eat the chicken.
Yeah, yeah. And you know, another thing, Gina, is so important because you know, people live with HIV have a lived experience and they have a voice, and they can like bring something to that table, and those planning as they roll out the implementation of them is to make sure that they are providing a stipend or honorarium, and not talking about give me a piece of chicken and a token for me to catch a bus. Right. You know, economic justice is really important and very one of our core policies that PWN believes in. And making sure that rolls out across the spectrum when we're talking about having people take the time to learn a certain thing and come to those tables to make change that fits the reality of our lives. There's a lot of things depending on the culture of a certain group of people may make an implementation of a plan different and better. Right. But if you don't have those people at those tables talking about, well, the cultural differences at that time, and you roll it out, then it's not going to work. And then you want to ask yourself, I don't understand why it didn't work. I do. You didn't have the right people at the table. That's why.
Yeah. So thank you so much for sharing what is going on in Louisiana and Pennsylvania. The chat is rich with a lot of questions and comments. And we have Anna, who has raised her hand. Anna, I would just want to see, did you have a follow-on question around disrupting or pushing back? I noticed that you said that we want to make sure we do it at the local levels, because while protesting at USCHA is always very powerful and gets advocates energized, it doesn't actually bring the message back to the people who need to hear it. So I wanted to call that out and see if there was anything you wanted to add before we moved on to another question that we have in the question and answer.
Can you hear me now?
Sure can.
Okay, I've written a whole bunch down here, so I'm not going to say anymore. I think everybody's kind of knowing where I'm coming from, but really it's one of the most gratifying and powerful things that I've ever done, walking into a meeting like that. And everything that you both were saying is the truth. And you just have to walk in and bring your people with you, and bring preachers and social workers and other people that the government folks can't just brush away, and say what you got to say.
Yeah, in Colorado, I'll just share, we have our PWN shirts because we have a pretty mobilized group, and we have shut down more health department meetings, more legislative sessions than we probably have any right to. And so we show up wearing our PWN shirts, and everybody takes a step back because they're just like, oh no, they've got their shirts on, someone's going to get their ass kicked. And it's like, you know what? That is not such a bad thing to have people sort of live in a little bit of fear that community is going to stand up and push back. Because again, as Allie really described, these laws impact people's lives. They impact through the whole process. And it's going to be really terrible if they just have an entirely biomedical approach that doesn't serve the needs or the intersectionalities that we know and the complexities that we know HIV involves as well. So thank you, and I really appreciate all of your ideas and all of your comments in the chat box as well. And I'm going to make sure that Tammy has an opportunity to copy the chat box, because Tammy, I think these are really great points that we want to make sure we capture when we're talking about this further at HIV is Not a Crime, and hopefully everyone will be there to join us. So we do have a question in the Q&A from Julia Zigman. Julia's question is, Gina and Teresa, can you share what role you'd like to see a local health department play in building community relationships, and an example of a way you've successfully engaged with the local health department in the past?
Oh, wow, that's a great question. So what here in Philly, we had the health department called ACO. We actually showed up, right? I called the director, said we were coming, and we actually showed up. He didn't think we was going to show up. And we actually brought questions to the table. We also asked him how we can get involved, and talked about the gaps that we had seen in our community in Philadelphia. Our local director of ACO is a very, I want to say that he is willing to go an extra mile for you, but sometimes it's limited because he has guidance of things that he has to do. But we also wanted to make sure that he knew that PWN Pennsylvania was here. We went up, we showed up a couple of times. We showed up with national, some of the national staff at the health department the second time we showed up, and we kept showing up, right? Till he actually got to the point where, like, okay, here's what we could have you involved in. And we got involved in making a difference in the rollout of community engagement, educating our community. There was some funding that I get every year now sent to me to make sure that I am hosting certain kind of community engagements for our community in Philadelphia, bringing awareness to several topics, right? Talking about PrEP, talking about intimate partner violence for women, hosting house fairs, hosting prevention summit webinars, certain things that we get funded to do from the health department. So we didn't just want him to like have us engage in certain things to that they were rolling out. We wanted also to have some money to do it, right? So we make sure that we got money. So I get money every year allocated for a certain community engagement initiative that we do here locally in our chapter for PWN. So that's how we got involved as far as like trying to make sure we had community engagement with our health department. We also make sure that we're sitting on those planning councils too, the Ryan White Council. We got several members who sit on those councils as well, to be involved about what's going on. But more importantly is that they bring back the information, right, to those who didn't get it, right? I often see a lot of people sit on planning councils and will take the information, internalize it for themselves, but they don't disseminate it back to the community, right? Who needs to hear it? They need to know what's going on. So that's really important if you're sitting on any kind of planning council, is to make sure that you're reporting back to your community any way you can, whether it be in a newsletter, whether it be in a focus group, whether it be in an educational program, that you're bringing the information back to your community and have them answer some questions. And if they got some questions, and making sure that whatever questions or unmet needs they think they need to address comes from them, right? Because their voices need to be part of this. Too often we see our voices being silenced or not even there. As sometimes even with criminalization, we have people living with HIV who are actually against it. And it just shatters me to know that. It's just that with some people think like it's okay to criminalize people for a health condition, right? And I don't want to say that they don't know, but I think they lack the knowledge about HIV on so many different levels. And that's when because I'm an educator, because my teachable moments of people who don't know. I'm not going to like look down at them or get angry. I just take that opportunity, because that's what it becomes. It becomes an opportunity for me to educate them. My teachable moments, even when it comes to people who are like in the prison system, we also engage with them throughout the years, where we actually went up to the prison systems. The majority of us who went up were people living with HIV, and we did roll call. 101 HIV roll call, and we educated those who were getting ready to, shift change, right? And we did every shift change from 7 o'clock in the morning, 3 in the afternoon, 11 o'clock at night, right? For the whole month of June, part of our prevention summit and our prison summit, just to bring an education around that in the prison system. We made some wonderful strides and changes, but there's so much more work that has to be done in this prison system right now, because I often say that all that stigma and misinformation is in our communities. And who do we hire to go work there? People from our communities, and they bring that in with them.
Great, thank you, Teresa. Gina, did you have anything that you wanted to add about that? We do have a couple of other questions if you would want to move on to any of those, or I did want to give you that chance to answer that question as well.
Okay.
All right. So Gina, then the next question that we have, and this is a powerful one, it's from Morgan, and it is: for advocates who are in regressive states working with ending the HIV epidemic, are there any tips you have for advocating in ways that aren't going to undermine progress? So in Alabama, I have to walk a very tight lockstep when advocating at the state level, because we have so much on the line with every legislative session regarding our rights. These people who use drugs, people who are living with HIV, because they don't want us to have them in the first place, it seems. I am always afraid that running my feisty, give no F's mouth, me too, might do more harm than good, but the show up squad is limited here, and there aren't many other people who will talk for me. Do you have any thoughts about that, Gina?
I would say form a coalition with those other groups, and let the issue of people be the issue. Don't let it be about injection drugs or HIV. It's people. We're here to talk about people. We're gonna keep it at that. Our legislators, they want us to be afraid. They want us to walk in and not say anything, because then they win. The more noise we make, the more we bring something to bring attention to something, the better off we are for that. So I understand the politics in Alabama a little bit, not a whole lot. I mean, I'm in Louisiana, what can I say? Not that much difference, I'm sure. But we have to do it. If we don't do it, who's gonna do it? And we sometimes try to walk that tightrope, and we don't get anything done because we're trying so hard to not upset the apple cart. I say take that MF and turn it over and make as much noise as you have to, because this is our lives, and I want to go back to something Teresa was saying about the health departments and getting something, and all of that. we did a Black Women in PrEP work group at our health department. I was on that work group. And every time I would say something, I would get drowned out. And I was the only woman that was openly living with HIV. And finally, I had to ask them, would you take PrEP? Would you take PrEP? And nobody on the call would say they would take it. So then my next thing was, well, maybe y'all might want to be quiet and listen to somebody. If PrEP had been out before I got my diagnosis, I would have taken it. So let's have that conversation. You know, so health departments need to listen to us when we speak.
Yeah. Thank you, Gina. So we do have one more question in the question and answer. Todd, I'm going to try and get to it, but I want to go ahead and make sure that we go back and finish up with some of our take action and next steps. And that's the glory of being able to adapt slides in process. So Allie, I'm going to turn it back over to you to talk about taking action. And you notice that I had to add a bullet point to here about disrupting, because it feels like that is the place that we are at.
I was going to say, I think everyone should just read the chat if you want to know how to take action. Seems like there's a lot of good material in there. Lots of folks with great ideas about disruption. And I'm sorry, all my cats and things are coming into the camera here. But yeah, to take action, definitely figure out who is leading the EHE planning process in your area, be that your state, your county, your city, whoever is doing it. Try and get involved with them so you can see who's doing it, what updates are going on, what stage are you at. You can use this website that I linked here. There was also a good one that someone shared earlier in the chat with a whole directory of folks, but it's on this same website. But yeah, definitely. And if it's not on the map where who's leading it, definitely contact the health department or something like that. And yeah, get involved in the planning process, especially if folks aren't getting community engagement. Definitely push for that. I think someone mentioned this earlier. Gina, I believe, mentioned this. Form a group of local advocates. Form a coalition with those folks to read through the plan, to come in with talking points, and discuss changes that are needed. Talk about those gaps that Teresa mentioned that are present in the plans, and go in there and have those talking points ready. And then, yeah, get some local disruption going. Speaking truth to the powers that are planning these things. And, you know, if they're not letting you in, make yourself present there in any way you can. So I think that's what I've got on that, I believe. Oh, yeah. And then the other thing to do, if disruption is maybe not your style or you're worried about perceptions, you could do some letter writing too, especially if you've got a big group of a coalition of folks who you're working with, to send to the planning committee to ask for meaningful engagement of people living with HIV. Ask for some reconsiderations of the plan if you're seeing gaps and things and it's already being implemented. Another thing you could also do is feedback is being accepted by HRSA. I have the email link down there about the EHE process. So they just have this email open where if you have comments about the EHE process and issues with it, we are in an administration right now that may be more receptive to changing some of these things. This process was implemented by the last administration. And so changes might be receptive right now. So you could send feedback about, hey, there's no metrics for community engagement. There's no meaningful involvement of people living with HIV. Maybe we should limit MHS and including human rights metrics in the EHE plans, including HIV decriminalization. You can draft a letter with either yourself or a coalition of local advocates or a larger national coalition and send it to that email address. They have it open there for comments. So I say, flood them with feedback. So I think that's all I have. But I'd love to continue the discussion if anybody has any more questions. Oh, and I'll drop some of these links in the chat too, just some fact sheets about HIV criminalization that we've created at PWN, and some other resources as well. So
Yep, and the Kaiser Family Foundation is very new. It just came out, and it is about what you need to know about the EHE initiatives. And so that's a very helpful one that has a lot of current information in it if you are interested. And with that, we'll go ahead and so Todd, your question was, do you have any best practices on how to integrate the Ryan-White Planning Council with these EHE planning and oversight? Todd's in Indiana and is new to the Ryan-White Planning Council, and it seems confusing how the health department is going about setting up the EHE planning and oversight in relationship to the Ryan-White Planning Council. So the best advice I would have to you is go ahead and get with the leadership of the Planning Council, and even with other people, people living with HIV. I don't want to make assumptions about your status. People living with HIV who are on the Planning Council, there's a requirement that a particular number, I believe it is 30%, 33% need to be people living with HIV. The number changes back and forth. And so have a meeting before the meeting to talk about what you are comfortable with and what you are pushing back on, because certainly it is easy to feel like we don't want to push too hard because we don't want people to get angry. And a lot of times people don't want us to be empowered because it slows the process down, causes problems, means there are more meetings. And I would roll up with the understanding and the knowledge that we are speaking for our lives and the lives of people in our communities. And so now is the time, if ever there was one, to roll up and push back and be loud. And I love Anna's comments in the chat box around making, if there's a preacher, if there's someone who is a pastor who can come with you, especially in their little collar, that tends to get a lot of attention in good ways for them to know that there are faith communities that support both the rights of everyone, but especially the rights of people who are vulnerable to acquiring HIV or who are living with HIV. And then there's a couple of great chats and resources in the chat box that we'll go ahead and do. And I'm going to go ahead and put in our link to our survey evaluation. One of the things that we want to know is how we did. This was a big topic, and we had a lot that we wanted to try and cover. I tried to argue for an 8-hour webinar, but people said that they wouldn't do that. Go figure. I guess Zoom fatigue is a thing. But anyhow, I want to go ahead and see if Gina and Teresa have any last thoughts that you want to bring up before we sign off.
I think it's a great idea to create things that you know that are not there that are needed, and finding people who share your same values and want to make the same changes, and they're looking through the same lens that you're looking through about creating something that will improve the lives of people living with HIV. We partnership with several organizations here. The AIDS Law Project, the Searle Project is here in Pennsylvania. We formed our Pennsylvania HIV Justice Network to talk about HIV criminalization. We wrote in collaboration with a lot of organizations and advocates and activists a white paper about HIV criminalization, which lives, if you want to read it, on the AIDS Law Project website. And just making sure that you're not doing this alone, right? The power is in the numbers. We make change when we bring people along with us. I don't want anyone to be out there being a lone wolf, right? And make sure that you are doing your best to make sure that you're not just talking to just a entity of something, but you're actually finding out who the person can make the change you want, and you demand that person to do that. We often forget the power that we hold. We just did it for 2020. When we went in there and we voted like crazy across this country, and we seen and made the change that we wanted to see, but we still are going to hold fire underneath this new administration, right? To make sure that they do and make sure that people living with HIV is part of anything that they roll out when it comes to funding, planning, programming, and ending the AIDS epidemic in the lifetime of people living with AIDS.
Thank you, Teresa. Gina, last thoughts?
Just want to say, we have to keep fighting. We have to keep fighting. It's too important to not. And we have to do it together. So thank you, PWN, and Cyril and everybody for putting this important panel together, this discussion. And thank you, Allie. I've never worked with you, but thank you so much. I gained so much insight in your presentation. So thank you.
Thanks, Gina. Nice.
And Allie, did you have a last word? Okay.
Me, myself. No, I'm good. Just thank you all so much for coming. Really appreciated it. Gina and Teresa, learned a lot from you as well. And yeah, I just hope we can all get out there and start getting involved in these plans. And I read a lot of them for this. And there's a lot of work we can all do. So it's very exciting to talk to you all about how we can work on that. So.
Excellent. All right, thank you. Thank you, Allie. We're a little bit over time. I appreciate everyone hanging in with us. And thank you again to Alejandra for the language justice, making sure that this was translated and accessible to all of our communities. And with that, hope to see you once again on the road to HINAC and actually at the HIV is Not a Crime conference. It is a powerful opportunity for us to come together as community and to plan out our ongoing efforts as we really work to remove any laws that are criminalizing people living with HIV. So with that, this is Barb Cardell, and I want to thank Allie and Teresa and Gina, and especially the Cyril Project for hosting us today. And with that, I hope everyone has a great afternoon. Stay warm and safe, and take care. And we will see you all soon. Thank you.